Welcome and thank you for joining us for tonight's webinar, Schizophrenia and Schizoaffective Disorders in Youth and Adolescents. My name is Sydney and I'm from the PHN Education team, and I'm joined tonight by Dr. Rana Singh. Before we begin, I'd like to acknowledge the traditional custodians of the land that we live and work on. For myself on the Central Coast, that is Darkinjung land, and I'd also like to pay respect to all elders past, present, and emerging. Now, a few things to let you know about this session. It will be recorded and available for you to view in our education library, along with a copy of the presentation slides in a few days' time. You'll also find the PDF of today's session in the Materials tab on your screen. And as attendees, your camera and microphone are automatically disabled. So if you do have any questions throughout the presentation, please pop these through in the question box, which you will find located within your control panel. We will go through these at the end of the session. Now, also an evaluation will come to you directly after the session. Your feedback is extremely important to us as it enables us to provide this type of education. I will also send certificates to all of you that are in attendance today. And if you're an RACGP member, I will upload your 1 hour of EA, hopefully tomorrow for you. Now I will hand over to Dr. Rana Singh.
Thank you, Sydney. Good evening, everyone. My name is Vimala Ranasinghe. I'm one of the psychiatrists working for Central Coast Local Health District as a staff specialist, working in child and adolescent mental health team. I have a separate team called EP team. I will discuss the little bit about my team and their role. And in addition to working in mental health team for the Central Coast Local Health District, I worked in Brisbane Waters Private Hospital as a clinical director there, and working in the inpatient unit in Brisbane Waters Private Hospital, as well as in outpatient clinic. So that's my sort of introduction, and then we'll go to acknowledgement of country. I begin today by acknowledging the Darkinjung people, traditional custodians of the land of which we meet today, and I pay my respect to the elders, past and present. I extend that respect to Aboriginal and Torres Strait Islander people here today. So we'll go to the objectives of the presentation today. As you have seen, topic schizophrenia, schizoaffective disorder, first episode psychosis, and mainly focusing on psychotic illness in young people, mainly youth. I like to focus more on teenagers from age 12 to 24. That include teenagers and young adult up to 24. So I would like to cover areas like the first episode psychosis and the assessment and challenges. I would like to give update about diagnosis and differential diagnosis in this age group. I like to discuss briefly the referral pathway and to discuss the psychosis management as well as comorbidities management in primary care setting. I will discuss two case scenarios to give a little bit of understanding of first episode psychosis and what are the things we are doing in child and adolescent mental health team. Okay. I hope you can see all my slides. As we know, psychosis is a very loose term, and it's if someone comes saying I'm psychotic, or someone says psychosis, we have to ask so many questions to narrow down the diagnosis and come to a definitive diagnosis. So it's a very loose term. As I mentioned, describe loss of contact with reality. And psychosis develop due to many reasons, multiple reasons. Primary reason of the primary reason psychotic illness develop due to functional psychotic illness. If I name few functional psychotic illness or primary psychotic illnesses are schizophrenia, schizoaffective disorder, psychotic depression, things like that. And obviously, you as a GPs or primary health care providers, you might have seen so many substance use disorder related cases coming as drug induced psychosis. And rarely we see psychotic illness due to neurological and medical conditions as well. So during the assessment, we focus on all these areas in a way to get history and exclude some of the conditions and use a specific diagnosis to treat the client. So as I mentioned, it's a very loose term, and psychosis has various different components in it. Common psychotic symptoms we see, two common symptoms are delusions and hallucination. You all know delusions are false and fixed and false belief without good insight into that. Persecutory delusions are very common, and where client feel that there are persecutors around him, there are people to harm him or her and cause trouble to the client. There's another delusion, common one called referential delusion, where a patient or client feels that the other people talking about the client, talking about him or her. And obviously grandiose delusion, where the client feels that they have special powers and abilities and things like that. So simple definition is it's false belief and it's very fixed and very lacked insight. So if someone can give a sort of rational argument, rational discussion to the client, very difficult to change these delusions. Second common, the other common psychotic symptoms is hallucinations, where we feel that the client feels that uh, there are certain things like voices or seeing things which other people cannot see. So definition is perceived experience in the absence of external stimuli. Common auditory hallucination in schizophrenia is second person auditory hallucination. Someone is talking to the client. There's another one called third person hallucination, auditory hallucination, where client here there are two people discussing about the client. Visual hallucinations, where clients see unusual things the other people cannot see. Those are common phenomena. And in addition to those phenomena, schizophrenia the patient with schizophrenia can experience like smells, tactile phenomena, tactile hallucinations, and so forth. Disorganized thoughts are also very common in schizophrenia. We can't see their thoughts, but when someone is talking or speaking, we can see that their thoughts are not very connected and very sort of disorganized. And other symptoms are disorganized behavior, where the client can be aggressive or incongruent or emotionally detached. And negative symptoms and schizophrenia also common symptoms in this type of condition. So I would like to bring clinical staging of schizophrenia and related disorders. Uh, this staging was developed by Professor Patrick McGorry in Melbourne. He was an expert in first episode psychosis and grading. And reason he developed this is he involved in developing Headspace and in first episode psychosis and youth mental health. And argument was that early identification of first episode psychosis is necessary to reduce the future comorbidities or future consequences, negative consequences, I mean. You can see number 2 is first episode psychosis, and number 0 is increased risk but no symptoms. What is the meaning of 0, increased risk and no symptoms? For example, if someone is coming with very strong family history of psychotic illness, schizophrenia in that matter, so that client has high risk of developing schizophrenia than general community or general population. So say if 16-year-old student comes with uh, anxiety or other symptoms, non-specific mild symptoms, we need to monitor that client because that client can go into psychosis or schizophrenia. Increased risk in 0, 1A and 1B, they have milder symptoms but not enough to diagnose first episode psychosis. When it comes to number 3, they have full-blown psychotic illness and with or without relapses. And when it comes to number 4, very severe, persistent and unremitting illness. So we mainly going to talk about first episode psychosis number 2 and some risk factors of developing such illness. Pre-psychotic or prodromal stage. You might have heard this word prodrome, and that's the stage before developing first episode psychosis or before establishing a diagnosis. This client present with some low grade symptoms. Occasionally hears voices and sees unusual things, and they present with some sort of anxiety and some functional decline and things like that. But there are no clear hallucinations or delusions to diagnose first episode psychosis. So prodromal psychosis, prodromal stage, we observe mainly in young people, usually age between 14 and 35. If we narrow this, it's more 16 and sort of 24 age group, more prevalent in that age group. Males develop prodromal symptoms earlier than females, and then same thing, diagnosis of these disorders, male get diagnosis early than females, few years early, I would say. If someone is presenting with unexplained functional decline, if some school student come in to your clinic saying that grades are going down and worried about the future, and patient is or family is unable to explain reasons for the functional decline. For example, if some school student grades are down without any reason, same school, same educational level, no substance use, no family issues, but things are not going well. So we have to assess that client and see what's going on, whether this is depression, whether this is psychosis, whether this is anxiety. It's possible that client may be developing psychotic disorder. That's why early interventions are necessary. So if such client comes, uh, obviously as a clinician, we need to monitor the mental state and monitor them regularly in a regular intervals and provide some psychological therapy if possible. That way we can keep them in the loop and then observe whether there are any uh, psychotic symptoms developing. As I mentioned, prodromal stage, there are no clear psychotic symptoms. That client may develop psychosis or may not. If not, that's a good outcome, but better to monitor and provide psychological interventions. Uh, Prodromal stage may be due to depression or substance use or issues in interpersonal relationships. Vocational or family stresses should be taken into consideration. And as I mentioned, prodrome is in prodrome, we can't find a reason. So if client has any other problem like family stresses, we better help them to manage the situation. So first episode psychosis, that's our main topic. At least 1 week or more positive symptoms of psychosis is necessary to diagnose first episode psychosis. Those symptoms are hallucinations or delusions, disorganized thoughts, disorganized behaviors, catatonia. Those are the main symptoms. If someone is having those symptoms more than a week, yes, this is a first episode psychosis. The diagnosis depending on the kind and pattern of symptoms. If someone is having psychotic symptoms with depression, it may be psychotic depression. If someone is having only psychotic symptoms, it may be first episode psychosis developing to some other conditions like schizophrenia. Duration, obviously, and other factors. In this situation, sometimes we diagnose drug-induced psychosis, and it is a common phenomena. Some clients or some young people present with psychosis and they are taking drugs or stopping drugs. So it's the common phenomena during the assessment. So differential diagnoses are, first one I would like to mention is schizophrenia. Obviously, the patient with schizophrenia should have symptoms more than 6 months to diagnose that. And common myth, according to Origin, Origin is an organization in, not Origin in Melbourne, where Professor Pat McGorry works, and his center is there. And according to them, schizophrenia is not as its myth is schizophrenia is a split personality. So it's not a split personality; it's a very clear cut diagnosis. So myth is schizophrenia is a split personality. So that mention in their papers commonly that schizophrenia is not a split personality. Schizophreniform disorder. This is almost similar to schizophrenia, and symptoms are similar like hallucinations or delusions, disorganized thoughts, disorganized behaviors, but the duration is less than 6 months. So 1 week symptoms or more, first episode psychosis, and then it goes to schizophreniform disorder according to DSM-5 diagnostic criteria. And if it is more than 6 months, we can diagnose schizophrenia. Bipolar affective disorder are common differential diagnosis in this age group. So in bipolar affective disorder, you should have period of depression, hypomania or mania, mainly change in mood and behavior and thinking. Bipolar affective disorder, especially manic clients, shows psychotic symptoms, common psychotic symptoms, I would say, is grandiose delusions. They have higher powers and higher abilities, things like that. So it's not uncommon to see psychotic symptoms in bipolar manic patient or bipolar depression in that matter. Schizoaffective disorder, where symptoms of schizophrenia and bipolar illness are present during the episode. So, as I mentioned, drug-induced psychosis, very common differential diagnosis nowadays, and especially in the age group we are talking about, age uh, 15, 16 to 24, and it can be due to withdrawal symptoms of drugs or due to effects of drug. So common ones we see in our clinical practice are amphetamine related or methamphetamine, speed, ice, that type of substances can cause drug-induced psychosis. Uh, Cannabinoids also can cause psychosis. Not only illicit cannabinoids, prescribed cannabis also, especially THC, tetrahydrocannabinol, THC are uh, uh, common substance that can cause psychotic illness. And stimulant use in ADHD obviously can cause psychosis, can trigger psychosis, especially in uh, susceptible individuals or vulnerable people. So I have a brief case summary in a few slides, in few minutes, so we can discuss how stimulant like Ritalin or methylphenidate in that matter, or dexamphetamine causing psychosis. Other conditions causing psychosis, as I mentioned, psychotic depression, where predominant symptoms is depression, where patient has very low mood, severe anhedonia, sleep disturbances, eating problem, weight loss, suicidal thoughts, psychomotor retardation, and they can develop psychotic symptoms. Uh, and Other less common disorders are brief psychotic disorders, medical condition causing psychosis. So I would like to go to first case summary. This client was in our early intervention team, EP team. Uh, he was referred in mid 2023. At the time, he was a 17-year-old teenager and brought in by family to emergency department, late admitted to PEC unit, psychiatric emergency care center, at Wyong Hospital. That's 2 years ago. Uh, the collateral history showed that client had a functional decline for 2 years, and he was increasingly religious. Religious doesn't mean that he was going to church or any religious place. He was studying more and more religion online and other ways. He was getting books from library and studying religion. That's the only interest he had at the time. And he was aggressive towards family members. He was talking to himself. He had significant sleep disturbances. uh, it was not uncommon family to not to accept this type of conditions as psychotic or any significant illness. Uh, there was a significant denial from family side to accept that this may be a psychotic illness. They started blaming COVID lockdown. You can imagine that this is mid 2023 and he had 2 years functional decline. that goes to mid 2021. That's the time COVID was severe and there were lockdowns and things like that. So father clearly mentioned that uh, the client was unable to go out because of COVID, and issues were exacerbated more because they were not happy to get the vaccine. So they were more isolated in their own home. So client was obviously more interested in religion, studying and things, but the other functional other areas of functions were declined. No social interactions, no hobbies, no friends. All these things were considered as significant. He previously worked in a shop briefly and had completed a short course. There were no history of substance use except when he was 14 or 15, occasional use of cannabis. That was few years ago. There were no family history of psychotic illness. There were family history of trauma related conditions, especially in mother's side, and so he was admitted to PEC unit at Wyong Hospital, where he was seen by a number of psychiatrists. And first episode psychosis, schizophreniform disorder, disorganized schizophrenia were sort of considered. So after 2 weeks, he came to our team, early intervention team, young people psychosis early intervention team. And generally our team managers can manage a client up to 2 years. That involves case management, psychiatric follow-up, investigations to monitor comorbid conditions or metabolic syndrome. So he was with us 2 years. Medications like aripiprazole and lurasidone were prescribed. After 2 years, he was on this medication. Number of occasions we suggested clozapine because client showed very clear negative symptoms. Negative symptoms are it's not like hallucinations and delusions. They have significant anhedonia, amotivation, apathy, avolition, elogia. Those are the anhedonia is lack of interest or loss of interest. Amotivation, obviously, the word mentioned no motivation. Apathy, evolution is lack of energy in the body, and elogia, not talking much, lack of speech. So he had all these symptoms. Because of that, we diagnosed him with negative symptoms of schizophrenia. So we suggested clozapine treatment. Unfortunately, family were reluctant to consider that obviously due to risk of side effects. We have referred him to various NGOs, including RIS, Regional Youth Support Service, and few NGOs locally. Unfortunately, client was unhappy to engage with them. So we did our best to improve his activities. Our case managers were very active. They were taking him out and going for a walk during the discussions and that type of things. Unfortunately, other than that, there was no significant activities. 2 years after follow-up, we referred him to our adult mental health team, assertive outreach team, for further follow-up. Unfortunately, it's not a positive story. However, this is how psychosis develops and becomes chronic and treatment resistant. Clozapine is one of the medication we use for treatment resistant schizophrenia. Unfortunately, they were not very keen on that. So first episode psychosis assessment is very important. It include engagement and developing therapeutic relationship with the client as well as with the family. Always we bring family in and discuss the issues. Uh, 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 we gather information to formulate and diagnose the condition and contributing factors. If there are any contributing factors, we can help the client to resolve those conditions. And assessment is important for planning the treatment, and generally we have very youth friendly approach. Our clinicians are well trained in early intervention as well as a youth friendly approach. So these are the number of domains, the duration of symptoms, prodromal symptoms, and whether there are any positive symptoms or negative symptoms, how severe are they, how that type of symptoms affect into their functional level. Especially at this age, they are in school or university or studying, so whether there's any significant effects on their functional level. And obviously we have to assess pre-morbid personality, the personality style before developing this type of condition. We need to understand if someone has very isolated, withdrawn, not having friends, the personality is different to a person who is having a very outgoing personality. So the decline is measured from that level to current level. And we obviously see their coping skill, problem solving, and their accommodation, family support, financial situation, all these things. Biological assessment is necessary because 3% up to 3 or more, around 3% of first episode psychosis client shows organic causes, organic origin for the psychosis. So better to exclude any organic causes. And biological assessment is helpful to understand any other medical comorbidities, such as obesity or hypercholesterolemia, uh, any blood sugar issues, things like that. And biological assessment help us to guide future treatment as well. If someone is having a high blood sugar level or evidence of metabolic syndrome, we can select the medication appropriately. Substance misuse, again, as I mentioned, is a common in first episode psychosis. 60 to 70% of people present first episode psychosis client report substance use compared to their peers in Australia. So that's a huge chunk of a client. So some of the client who are presenting to first episode psychosis or drug-induced psychosis and psychosis to emergency department, they do not come to our service sometimes because very clear that drugs are causing that. But better to arrange some sort of follow-up for them because it may be schizophrenia or similar conditions. Cannabis, alcohol, amphetamines are common substances, as I mentioned. So if I go to case summary 2, this is a 20-year-old woman. She was referred to us maybe 15 to 16 months ago, 1.5 years ago. And she, at the time, 18 and a half, she was admitted to medical ward through emergency department with behavioral issues and catatonic symptoms. Catatonic symptoms are like she was in certain guest, she was like a statue. She was unable to move well, and her muscle rigidity was high. And there were evidence of delirium type symptoms at the time. So she was admitted to neurology unit. Neurological assessment was completed, where MRI was done, EEG was done, basic investigations were done without any significant positive finding. As she developed this condition very sort of rapidly, they suggested lumbar puncture, but family was reluctant to consent for that, so that was not done. But MRI is EEG and basic investigation were done. And prior to that, the client was on Vyvanse, lisdexamfetamine, 70 milligrams for ADHD. And she was on lisdexamfetamine or Vyvanse for a while, but dose was gradually increased to this level. As you can see, obviously, she had a history of ADHD and mild intellectual disability. I would say mild because she finished school and she was planning to do some courses, TAFE courses. So mild intellectual disability was considered in the past, but her the functional like friendship, interaction, social interaction, all were within normal range. So when she was in PEC unit, there were evidence that she had delusions of control for 5 weeks. This is a different kind of delusion where patient feels that someone is controlling their thoughts and behaviors and actions, as it's like outside control. The client was unable to control, outside person is, or someone is controlling that, or some machine or some way their movements and behaviors were controlled. So that's a delusions of control. So first episode psychosis obviously diagnosed because she had symptoms more than a week. It's up to 5-6 weeks. Medication induced iatrogenic psychosis was considered because she was on 70 milligrams of Vyvanse. Obviously, Vyvanse or lisdexamfetamine was ceased straight away. Olanzapine was started and lithium also was started and referred to our team. When she was coming to our team in 5 to 6 weeks, she started to gain weight, 5 kilograms or something for shorter period, and then we have noticed that she was gaining more weight. In our team, we generally go through the medication and found olanzapine is the reason for weight gain. We gradually change it to brexpiprazole or Rexulti and increase the dose to 2 milligrams. Lithium we cease gradually over a 6 month period because there were no effective symptoms during the follow-up. And around 16-15 months, she was on brexpiprazole 2 milligram. And for her ADHD, during this period, she has started a TAFE course to study hairdressing, and she has to do some assignments. So we started Intuniv or guanfacine for ADHD to support ADHD or improve ADHD symptoms. So over the last 16 months, she was very stable. So I was questioning why she developed psychosis at the time. One of the reason maybe Vyvanse or lisdexamfetamine. Another reason why other people are not developing psychosis on Vyvanse and she developed. She had a mild intellectual disability. Client with mild intellectual disability has more vulnerability to develop psychosis than general population. So those were two conditions, two sort of the uh, thoughts we had about her psychosis. There was no psychotic illness in the family, no drug use, and she was clean, no even smoking or no drinking. So those areas were protective factors for her. That's a positive story in that matter. She stays well on a very low dose of antipsychotic medication. After we change in medication, she started losing weight also. There was a significant improvement in that side. So early intervention is necessary to minimize duration of untreated psychosis. If someone develops psychosis and if it's untreated for a long time, the future prognosis is poor. For example, in my first case, I said the client had 2 years functional decline, and I consider that as a prodromal or psychotic illness, and there was no treatment for that at the time. So early intervention is helpful to ensure the safety of the client and safety of others. It's very common to develop thoughts like suicidal thoughts in this age group because this is very new phenomena, new experience, psychotic symptoms, very distressing. So they develop suicidal thoughts and behavior. So we have to monitor the risk like safety, suicidal risk, and other safety concerns. And they can develop thoughts, negative thoughts or harmful thoughts towards other people. So we have to assess that and monitor those things. It is very helpful to reduce the duration of untreated psychosis. As I mentioned, untreated psychosis is long untreated psychosis is a negative prognostic factor. And early intervention is helpful us to reduce the disability associated with psychosis. Uh, if client is getting a proper treatment, they can continue school, they can continue uni, continue work, and things like that. We have minimized the risk of the disability associated with that. And it involved holistic approach, including pharmacological and psychosocial interventions. So in early intervention team here with us, we have psychologists, nursing, OT, and social workers. And there are team leaders managing this team. Obviously, if you suspect someone with first episode psychosis or psychotic illness in that matter, best way to refer is 1-800 number, mental health telephone access line. I understand that sometimes it takes time to give the information and refer the client, and it is worth talking to them and give information, and then that team refer the client to relevant team. If client is above 24, obviously client will go to adult team or acute care team. If client is below 24, they will come to EP team or CAMS team. When client is referred to us, one or two clinician involved in initial assessment, they decide whether there are any evidence of psychosis or which team the client to be assessed to get a formulation and to decide the team. Then we involved in the management and assessment, and if psychosis is confirmed, we follow them up for 2 years, up to 2 years. And if not, we arrange follow-up through any other team or provide feedback to the referring person. It is not uncommon. We keep the client for 3 months. It's called extended assessment, where the psychiatrist or a registrar and team can involve with the client in a more extended manner up to 3 months across the time to make a decision. Again, if patient is not showing first episode psychosis symptoms, we can discharge and refer the client to relevant agencies. If client has symptoms of first episode psychosis or schizophrenia or similar conditions, we take over and manage them for 2 years. And it is not, I mean, we don't see much referrals coming from the primary care setting. Most of the client end up in hospital emergency department or PEC unit, and they come to our service after that. But I have seen recently, I got as I mentioned initially, I worked in Brisbane Waters Private Hospital as a staff consultant psychiatrist. Got a referral saying that this child, 16 or 15-year-old girl with psychotic symptoms. So I was able to refer that client to our team, early intervention team, and kept her there 3 months. And during the 3 months assessment, we found that there were no clear psychotic symptoms. All were related to serious childhood trauma and symptoms like dissociations, uh, emotional dysregulation, and things like that. So we were able to manage her 3 months and provide the adequate support and refer her to a different team. So it's not uncommon. We keep them 3 months and manage and discharge to the relevant organization. I think that may be my last slide. Yeah, that's my last slide. And if you have any questions, you can ask, and I'm happy to answer. And thank you very much.
Perfect. Thank you, Dr. Rana Singh. Now, we did have a question come through. In the cases of chronic stable schizophrenia, how often should they review by psychiatrist, for example, a patient with regular depot or depot antipsychotic for 15 years?
In our team, generally, I see them every 6 weeks, psychiatrist, not a registrar. Uh, I see them every 6 weekly, and case managers involved in their care uh, sometimes once a week for assessment through the case manager, or sometimes once a fortnight, depending on their level of acuity, which changes. But I myself like to see them every 6 weekly. Yes.
That was the only question that came through. Before I close out the session, we've got another one coming. I like this. Let's see. Okay. How at risk are siblings of patients diagnosed with schizophrenia? Are they screened?
The family history of schizophrenia and genetic risk is significant. If someone, their parents or siblings having psychotic schizophrenic illness, their risks are significantly higher than the general population. For example, general population schizophrenia risk is 1%. So if we take 100 people, 1% of chance of someone having schizophrenia. So that's a general. But if someone having a family member, the say parents, their risk is high, more than 10%. Similarly, siblings, same, uh, significantly higher risk. So those clients are considered as high risk or high risk client. So the problem is we can't screen all the high risk client, but if they are having other symptoms like functional decline, educational decline, uh, prodromal symptoms, or non-specific symptoms like anxiety, that client can come to our service for monitoring. So it's significantly high risk, but still up to 80-90% of the chance they may not develop psychosis, but risk compared to general population is very high.
Yeah.
So
Is there any difference if the hallucinations are second or third, talking to the patient or about them?
Uh, yes, that's a good question. Uh, when we diagnose schizophrenia, especially when we are in psychiatric training, there was a thing called first rank symptoms of schizophrenia. Uh, this Snyder's first rank symptoms. There are around 8 or 9. I can't remember number. Third person auditory hallucination. Third person auditory hallucination means two people or more talking about the client in a third person. He did this, he does that, and he is like that. All are generally a negative comment. They are discussing each other about the client. That is the third person auditory hallucination. Second person auditory hallucinations are someone talking to the client. You did this, something like that. And so the second person auditory hallucination sometimes can uh, uh, that voices can command the person to do some activities like aggressive activities, something like that. So specifically third person hallucination are pathognomonic of schizophrenia. That means if third person hallucinations are there, auditory hallucinations are there, that's schizophrenia generally.
Well, I think that's
Olivia,
it.
do you
I
want
will
to
keep it
add
open while
anything?
I hand over.
Olivia, do you want to
I think that was the
comment?
last
Or?
one. Yeah, I'll
Sure.
let Olivia chime in and then say something for today. And I'd like to also introduce you, Olivia. Now you are from the LHD with CAMS, and thank you for organizing and finding Dr. Rana Singh and providing his expertise to us. So thank you.
Thank you, Dr. Rana Singh, and thank you, Sydney from the PHN. Dr. Rana, this is such a relevant topic. I do get a lot of referrals from pediatricians and from GPs with concerns around 10-year-old and 12-year-olds that are hearing voices. What's your thoughts around that, please?
Um, the age group starting from 14, 15, 16 generally, and the kids in this age group early 10 11 12 can present with complaining of voices, but generally these voices are more internal things. It's more rather than a voice or hallucination. Those may be thoughts of their own, own head, someone's thoughts. So it's very highly related to complex trauma type of conditions, physical, emotional, neglect, sexual trauma. So those type of situation, these things are common phenomena. But when we tease out the voices and try to elicit whether this is hallucination or not, it does not consistent with hallucination most of the time. But we have to be very cautious. There may be other reasons to the kids to present with these conditions, severe trauma or problems. So better to have an assessment and see what's really going on. And personality disorders, on the other hand, they have this type of presentations.
Absolutely. Thank you, Dr. Rana. Yes, thank you for clarifying this because it is a topic of great concern, especially to primary health providers like GPs when they have a limited time to see a client and then the parent is quite distressed. My child is hearing voices. So it's good that you've clarified that point to everyone. Thank you.
I mean, if there are such a symptoms, it's better to get a little bit of collateral history, and even getting information or referring the client for some sort of counseling through the school counselor or someone to understand why the client or why the child is developing this type of symptoms, that age group. Obviously, I haven't seen age 10, 11, 12 client presenting with psychotic illness, and maybe 13, 14, that's the starting time, but very rare. But when it comes to 15, 16 years, that's the time the psychosis or bipolar, that type of conditions are emerging. Yeah, so 10 to 12, very unlikely, but better to do the assessment and assess what's happening. And I haven't
Well,
specifically mentioned about the medicines or anything, because it's all of our GPs, they know very well about the medication. The second, the atypical antipsychotic olanzapine, quetiapine, risperidone, obviously causing a lot of weight gain and metabolic problems. That's why we involved in changing the medication and then other medications. Yeah. Yes, Sydney.
yeah, perfect. Well, that was incredible, and I'm really thankful that you've come tonight. Thank you, Olivia, again. And just a reminder to everyone, when I end this webinar, you'll receive a certificate that you can download, and I will upload, if you are a member of RECGP, your CPD hour for tonight. But thank you, and we will see you all next time.
Thank
Thank you
you,
very much.
PHN. Thank you very much, Dr. Vanna Singh. Thank you.